So here we see a graphic depicting a wide range of different gastrointestinal disorders that are commonly seen in the pediatric setting. All of these are diagnoses and disorders that are commonly seen not just in the pediatric gastroenterology office, but also often in the general pediatrician's office. There are many complaints that will bring a patient to their physician's office for evaluation. Gastrointestinal symptoms of various kinds are common in the pediatric population, with abdomen pain being one of the most prevalent. GI symptoms can have a wide range of illnesses associated with them, as demonstrated by the graphic seen here. Today, we will start with a review of the evaluation and assessment of abdomen pain as a presenting complaint for a patient. We will then also be focusing on the two specific illnesses highlighted in red here today. This would be constipation and gastroesophageal reflux disease, also known as GERD. These are two of the main reasons for consultation to a pediatric gastroenterologist, and they have many practical management options for the pediatric outpatient setting. Objectives for today. We will be focusing on the most common conditions you are likely to encounter in the outpatient setting, this being abdomen pain, constipation, and gastroesophageal reflux. For each of these conditions, we will briefly cover common symptoms associated, more specifically for that disorder, first-line treatment modalities, and when to refer to a gastroenterologist. So first, as I said, we will be discussing abdominal pain. Abdominal pain is a commonly encountered presenting symptom in many different medical settings, and one which has had extensive studies and literature published on the topic. This slide is a screenshot of a recent PubMed search for pediatric abdominal pain, which has returned back over 9,000 results with the keywords of pediatric abdominal pain as the search criteria. So as we can see, this is a large and well-examined area of medicine. To start with our discussion of abdominal pain, we have here the Rome 4 criteria for defining functional abdomen pain in pediatric patients. The Rome criteria are useful diagnostic criteria in the diagnosis of many different functional disorders, including abdominal pain. A functional abdominal pain is defined as one which is distinct and without an underlying physiologic cause. Now, it is important to recognize this last point. Functional abdomen pain is diagnosed based on symptoms once appropriate medical evaluation has been completed and has not been able to ascertain an underlying medical condition for the specific pain involved. In order to qualify for as a functional pain syndrome, the patient must meet these criteria specifically. The important variety of information to obtain from patients should center on establishing possible underlying causes and goals for testing and treatment. Timing, chronicity, and location are some of the most important factors that you should evaluate and obtain from your patients. Establishing symptom relationships between each other for any coexisting symptoms in addition to the pain, such as nausea, vomiting, diarrhea, etc., can help with further direction in management and evaluation for the patient. Establishing relationships to meals as well as stress is also helpful in narrowing your focus for management and assessment. Relationship to meals can be very important, as there are many such factors which can lead to abdominal pain for our patients. Triggers such as lactose or other carbohydrates in meals can be helpful to inquire about, as these are common triggers for many patients with disaccharidase deficiencies. In addition to timing in relation to meals, the relationship to activities of daily living is also important. Establishing relationships with school environment, outside events, stressful triggers can all be beneficial and help to narrow out and find the potential triggers for your patients. Establishing bowel movement patterns, timing, duration, consistency, and coexisting behaviors or anxieties around toileting can also be beneficial. Family history may indicate possible disorders such as celiac or inflammatory bowel disease, which have a familial component to their course and occurrence. Your physical exam in these patients should be broad, while also paying a special attention to the areas your patient is indicating as related to their symptoms. Oral examination is important, as more subtle signs of underlying autoimmune disease, such as celiac or inflammatory bowel disease, can present with oral mucosal ulcers or problems with dentation, problems with the gums as well. Patients may have sour smelling to their breath with acid reflux. Deep palpation of the abdomen may elicit diffuse pain and tenderness, while patients with a functional pain disorder may better tolerate this deep palpation despite the degree of tenderness that they do have in their exam. Palpable stool could be felt in the abdomen during the abdominal exam. Also, presence of stool in the rectal vault and a digital rectal exam could also be another marker of their underlying source for their symptoms. Patients with only abdomen pain and lacking other specific symptoms or red flags may not actually require any specific evaluation or testing. However, in our daily clinic setting, we are often placed in the position where, despite our best reassurances, family are insistent and expecting we will do more for their child. When doing evaluations, do the best you can to keep your labs as specific as you are able to based on possible underlying causes in order to help with mitigating patient stress around the testing, cost, as well as use of medical materials. A few simple and readily available tests could include things such as a celiac panel. This is especially helpful for patients with a higher likelihood of positive testing if there is a family history, as well as patients with other related conditions, especially patients with type 1 diabetes and trisomy 21, which have a higher coexisting rate with celiac disease. Common labs such as CBC, ESR, and CRP are useful, as they give you a great deal of information on cell counts and markers of inflammation, but are very nonspecific with little predictive value for most gastrointestinal diseases. Patients with diarrhea may have stool studies looking for bacterial or parasitic infections, but keep in mind the likelihood based on the patient's symptoms and acuity, as most infectious causes would tend toward a short time course of symptoms. Stool calprotectin level has become much more readily available and more frequently obtained in all medical settings. While this can be a useful test, as with other inflammatory markers, it is a non-specific test result, and it can be elevated just as common gastroenteritis, as well as things such as inflammatory bowel disease. So it should be kept in mind the non-specific nature of that test. Imaging of the chest, abdomen, as well as things such as upper GI studies should be used based on clinical judgment and potential of finding radiologic signs of disease. These may be more likely to bear fruit in patients with underlying red flags, especially. As far as management goes, trials of dietary interventions are relatively easy and generally harmless to patients. Trials of things such as dairy-free diet or avoidance or cutting down of juices or other high carbohydrate sources and artificial sweeteners in foods may be beneficial things to try as some of your initial steps for these patients. Antispasmodic medications such as hyoscyamine or dicyclomine can be trialed as well. Both of these can be used for an abortive effect for symptoms as well as maintenance in some patients. These medications are especially useful in patients where there may be an anxiety or stress component and raising concerns for a functional disorder. Functional disorders is where they will tend to have the most benefit, although for abdominal pain in general, they can be quite useful. Simpler management options for more common disorders, such as gastroesophageal reflux disease or constipation, can also be attempted in patients who have corresponding symptoms. We will be addressing some of these interventions shortly. So, you have assessed your patient and are formulating your next steps. Some of your evaluation has come back and has not been helpful, and your initial treatments have also not borne fruit. Referral for additional subspecialty evaluation is likely where you are considering your next steps. Depending on the presence of red flags, referral may also be beneficial while evaluations are still being completed. The biggest red flags which may warrant earlier referral would be large and unintentional weight loss or growth delays, dysphagia, unexplained fevers, persisting vomiting, or nocturnal diarrhea or nocturnal stooling events. Next in our discussion, we will focus on the two most common specific conditions you are likely to encounter in the outpatient setting: constipation and gastroesophageal reflux. For both of these conditions, we will briefly cover common symptoms associated more specifically for that disorder, first-line treatment modalities, and when to refer. So first, we'll begin with constipation. Constipation is often associated with infrequent and/or painful defecation, fecal incontinence, and abdominal pain, all of which often leads to significant distress for both the child and their family. The most common concern in these situations is that there is a more serious underlying cause or one which is not treatable. It is important to remember that the majority of cases of constipation in children will have a functional cause and will resolve with medical and behavioral management. The Rome-4 criteria are the most common criteria used as part of the diagnosis of functional constipation. It is important to remember that in addition to meeting these criteria, evaluation for an underlying medical cause should also be completed so that it may be ruled out. Briefly, these are some of the more pressing and concerning warning signs you would be looking for in a patient you are evaluating for possible constipation, which may warrant more in-depth labs and imaging as well as possible referral. And we'll be discussing these a little bit more as the slides go on. Once the history has been obtained and there are no notable warning signs, obviously present, the next best step is obtaining additional information via additional evaluations. A digital rectal exam can be useful in patients whom it is not clear of the source of symptoms. This should be performed especially if patients only meet a single criteria for functional constipation or have any warning signs in their history or other parts of the exam. A commonly used method of assessment for both outpatient and inpatient settings would be abdominal films. If patients meet sufficient criteria based on their history and their exam, this study should not be necessary for their initial management of constipation or diagnosis of it. It has the most benefit in those whom a clear case for constipation as a source of their symptoms is present, or in those not responding to standard therapies and need for more in-depth evaluation would be warranted. Once we have established that we are managing constipation in our patients, the mainstay of treatment is the use of osmotic or stimulant laxatives, as well as dietary and behavioral interventions. Medical management should begin with a disimpaction of constipated stool. Use of both oral osmotic laxatives, such as polyethylene glycol or milk of magnesia, as well as rectal enemas or suppositories, have been shown to be helpful. Use of a single administration route is often the best to begin with. Patients with stool found on a digital rectal exam may benefit from suppositories or enemas alone. However, in many cases, carrying out an at-home oral cleanout with any of these recommended standard therapies should be sufficient to begin improving symptoms. Okay. Osmotic laxatives are going to be the most readily available and often easiest method to help treat constipation in the majority of patients. These are safe for both short and long-term use, with the benefit of avoiding dependency, which can be seen with stimulant laxatives. All of these work in all age ranges of patients and can be chosen based on provider preference, as well as patient-specific factors given the required dose for age and weight. Polyethylene glycol and milk of magnesia are likely the two most commonly used of this medication category and are both safe and effective for both disimpaction as well as maintenance therapy. Lactulose is less commonly used osmotic laxative due to its dosing requirements for older patients. However, I personally have had good results in my younger infants and toddlers with constipation. The largest benefit to this medication is that since the dosing is very heavily weight-based, younger patients often can be given only a few milliliters in order to be effective. And it is easily able to be titrated to achieve an appropriate response. It is also a lot of times easier as it does not need to be mixed with anything. So the volume that younger toddlers or infants have to take is usually only 20 to 30 milliliters at most. Stimulant laxatives, most commonly used being senna and docusate, are both stimulant laxatives that are useful to keep in our repertoire. Most patients should be able to be effectively managed without needing these medications. They can, however, be useful in patients with more difficult disimpactions, those who have failed an initial disimpaction, as well as patients with an underlying neurologic dysfunctions, which could be impacting bowel function or motility. Those with an underlying motility or neurologic disorder have a higher likelihood that they may require these additional stimulants to achieve regular stooling patterns. While these are clinically safe in general, regular use, especially daily, will require gradual weaning once patients are ready to come off medications. And these would generally be medications that are beneficial to scale back first when possible. Working on improving the toileting hygiene for your patients can also be highly beneficial in not only achieving, but maintaining good stooling patterns. Patients with constipation, especially those with any overflow incontinence, often benefit from a scheduled time on the toilet, in addition to going as needed. Taking advantage of the gastrocolic reflex following meals is often an ideal time for this scheduled toileting. Making sure patients have appropriately sized toilet seats, booster seats, and stepping stools to make themselves comfortable, as well as encouraging upright posture, can also be helpful to encourage appropriate evacuation of the bowels. Younger children may have anxiety or stress around stooling due to fear of things such as painful defecation or anxiety about using the bathroom, sitting on the toilet. School-age children should also be asked if they are using the restroom appropriately while at school. These can often be stressful triggers for many children, leading to ongoing issues not addressed adequately. Anxieties that a lot of patients have around using the restroom at school can include things such as younger children may be uncomfortable asking for permission to go, or patients may have concerns that the other children around all know that they're using the bathroom and they're embarrassed by it, all of which are important things to inquire about with your patients. While dietary sources of fiber from whole foods should be encouraged, many families will have questions about fiber supplements or powders. In addition to these, families also often will inquire about the use of pro or prebiotics for their child. At this time, there is no recommendation to use these in pediatrics due to there being a lack of sufficient evidence. However, we should aim to improve the quantity of fruits, vegetables, and water intake in our patients. Most patients should be continued on their maintenance therapy for a minimum of 2 months with consistent administration. The majority of patients can eventually be expected to come off their regimen once they've had consistent progress for at least 1 month before attempting to start backing off on their medication. Failure to either resolve symptoms or inability to be weaned off are good reasons for patients with constipation to be referred for further evaluation. The presence of warning signs, either with initial evaluation or subsequent care, should also be a time to consider further evaluation with a referral. Red flags to watch for specific to constipation can include constipation beginning before the first month of life, failure to pass meconium, a family history of Hirschsprung, patients with failure to thrive, those with lower limb weakness or discoordination, coexisting enuresis, and any patients with an absent anal or cremasteric reflex. Our final topic of discussion today will be gastroesophageal reflux. Classically, gastroesophageal reflux is defined as expulsion of stomach contents into the esophagus with or without regurgitation or vomiting. We pass into the definition of true gastroesophageal reflux disease when this expulsion of contents begins to interfere with activities of daily life. Symptomatology for gastroesophageal reflux disease can be quite broad and represent a wide range of upper gastrointestinal findings. The classic symptom of reported heartburn can be present in mid-chest and/or the epigastric region of the abdomen. Many patients may have the presence of emesis with their symptoms, but this can often be the only true presenting complaint until additional history has been obtained. A few clues which may also point toward gastroesophageal reflux disease could include things such as sour smelling breath, whether that be in the office itself, or oftentimes family members such as mother or father may report the patient has the sour smelling breath. This is often especially noticeable in the morning for many patients. There is also a chronic dry cough that may be reported, often confused with asthma. And this also tends to happen most frequently in the morning, although it can be periodically throughout the day. Additional warning signs we'll be covering again further in detail, but these are some that would necessitate a more urgent referral. Most patients with classic presenting symptoms of GERD should not require much in the way of additional workup. Response to sufficient dosing of acid suppression is often enough to make a diagnosis. Both pH probes and imaging have roles in diagnosis, but these should be considered in more abstract cases where the clinical picture is less clear. pH probes are often used in the diagnosis of GERD in infants or younger children, but evidence for its worth in diagnosis and management is unfortunately lacking, as documentation, especially in infants, of any refluxate often does not correlate with the presenting symptoms or physical findings that family is reporting that is concerning to them. Imaging such as barium swallows and upper GI studies are also common diagnostic tests which are often considered and performed in suspected patients. These mostly have value when used as part of evaluation for patients with symptoms of possible obstruction or blockage. Dysphagia and swallowing difficulties are not present in many GERD patients, but would be considered a red flag for possible other underlying disease process besides GERD that may require more in-depth evaluation. Here we're going to cover two specific GERD-related diagnoses. First, we have H. pylori. While H. pylori is present in the community, based on many studies in the pediatric population, it is not commonly found to be as often a cause of GERD as it is in adults. As such, it is mostly recommended that it not be included in initial testing for GERD or similar symptoms, as diagnostic yield is likely to be low. H. pylori testing could be considered in those who have confirmed close contact with infection, who also have appropriate symptoms, or failure to respond to standard treatments and possible exposures. The most accurate diagnostic tool for H. pylori is endoscopic biopsies. As this is not readily available, the quicker, although less reliable route for diagnosis would be stool antigen testing. This test should be performed on a stool sample once patient is off acid suppression for a minimum of 2 weeks, and they also must be off all antibiotics for a minimum of 4 weeks. Although it is commonly obtained, blood antibody testing is not a reliable test in diagnosis, as it can be a marker of prior exposure and does not necessarily indicate active disease. The other special consideration in the evaluation of GERD is that in infants, most often under 1 year of age, who will be presenting with recurring episodes of spitting up. These are most often following feedings, but can be somewhat remote as well. Spit up volume is usually less than the total volume of their feed, often under an ounce, however. Parents will often describe it as pouring out of the mouth or coming through the nostrils or nose of the infant. And many times on inquiry, the infant seems almost unbothered by the event. The infant will be achieving appropriate developmental milestones, growing well along their previous growth curves. Management for these patients is mostly education for family that appropriate growth and development indicate that they are receiving sufficient nutrition despite lost feeding volume, and that it will be expected that as long as the infant continues to grow and develop well, that as they age, these symptoms will begin to improve. In those patients who do seem more concerned, some attempts can be made with trials of different formulas, acid suppression, position changes, adjusting feeding volumes, adjusting timing of feeds as well. Mostly these are anecdotal and a case-by-case basis of if they're going to provide improvement, and for the most part, help with anxiety for the family members themselves, that they are able to do something and may be helping. Mainstays of management for GERD have most consistently been behavioral changes as well as medical management with methods of acid suppression. H2 blockers and proton pump inhibitors are the mainstays of management for the majority of patients with gastroesophageal reflux disease. These are generally tolerated well in most patients, and side effects, especially in the short term expected for pediatric patients, are rather mild, which makes them very useful. H2 blockers can have a role for patients with less frequent symptoms or symptoms tied to specific triggers. The short time course to achieve their effect is what makes them useful before a subsequent trigger, such as food or activity. It should be remembered, however, that over time, they will tend to lose effectiveness with frequent use. Patients needing management of daily or near daily symptoms would likely benefit more from PPI therapy as opposed to H2 blockers. PPI offers patients once daily dosing and stronger acid suppression compared to the H2 blockers. Important factors which can impact their effectiveness is not being taken on an empty stomach, generally recommended to be 30 minutes before breakfast, most often for most providers, as well as patients not taking them consistently daily, which is often a concern for patients they will only take them when they're having their specific symptoms. And it must be discussed with them ahead of time that these are important factors for the effectiveness of these medications. Prokinetics generally do not have a role in the majority of patients with GERD. These are usually going to be reserved for more severe cases, and if you feel these may be indicated, the patient likely would benefit from further evaluation with a referral to a gastroenterologist. Finally, another component to the management of GERD includes behavioral interventions. Encourage patients and family to keep track and watch for specific triggers for symptoms. This can often be useful as avoidance of triggers or pre-treatment with an H2 blocker can avoid symptoms before they happen. The classic way to handle this for patients is allow them to either carry a small pocket notebook with them, or they can use the notepad in their cell phone to record when they're having symptoms, when their last meal was, timing in relation to that meal. And over time, as family begins to review, they often will start to find specific triggers, whether it be foods or events, which are causing a problem. An important additional point to ask and inquire about with your patients is stress and anxiety. As a gastroenterologist, I have to say, during the course of the pandemic, we have noticed a huge uptick in the stress and anxiety level of our patients. I'm sure essentially every physician has also noticed this. Stress and anxiety play a huge role for a lot of patients as a common and often predominant trigger for their symptoms. Where possible, working on anxiety management and control of stress can be very beneficial. Patients who do have stress or anxiety around many different factors in their life often may also benefit from counseling, whether that be official counseling with a referral or even just counseling with their school counselor a few times each month may be beneficial. So when to refer to a gastroenterologist? Similar to constipation, patients not responding as expected to sufficient medical management or who are unable to effectively stop with medications should be referred for additional evaluation by a gastroenterologist. Important red flags to consider for patients with GERD that may necessitate sooner referral would include patients experiencing things such as weight loss, systemic symptoms such as fevers, rashes, any headaches associated with their symptoms, sensations of dysphagia, presence of hematemesis, or any inability to tolerate oral solids or liquids would all necessitate a more urgent referral to pediatric GI. So that brings us to the end of our discussion today. Thank you all for listening. I can now take questions.
All right, Dr. Buckley. Question, what's the role of breath tests for H. pylori?
So breath testing is useful for H. pylori. The requirements of being off acid suppression and antibiotics is present for that diagnostic test as well. They do breath testing over at the hospital. So if you have access, you can refer patients there for breath testing.
Okay.
And it would be similar if you were suspecting H. pylori and how you would use it, similar to the stool antigen testing.
And then how long do they have to be off antacids?
It is off all acid suppression for 2 weeks and off all antibiotics for 4 weeks.
Okay. So how long can a patient be on continuous PPIs?
So long-term, there is some concern for patients to have bone demineralization, and that is the biggest long-term concern for it. For the most part, I find the majority of my patients need to be on acid suppression for about 6 months. Usually I'm able to start weaning them to at least a lower dose, if not wean them off entirely. I find most patients are able to come off at least proton pump inhibitors by 12 months. And usually by that point, they've established for themselves what their triggers might be. And a lot of times they're either able to manage effectively with just avoidance of their triggers, or they're able to manage with an H2 blocker prior to eating a meal that might have a trigger for them.
Okay, so you might switch them over to an H2 blocker.
And just, yes, I'll switch them to an H2 blocker because it's something that they can use more acutely when they know they're going to be having something that is most likely to cause their symptoms.
And how long does it take for a PPI to really work?
In general, I recommend to my patients that they should expect to see some improvement within about 2 weeks of starting on the medication itself. But I really do see the biggest improvement and effect from the medication, usually by 4 to 6 weeks. So I always like to caution my families that they may not see that immediate improvement that a lot of families have. So I always make sure I let them know, just because you're not starting to see some improvement in your symptoms after 1 to 2 days. No, you must make sure that you continue on this for at least 2 weeks to really give it a chance to start working. And usually I'll see them back after that 4 to 6 week mark, so that I really have given them a chance to let the full effect of the medication start. Now, any patients who are seen in the hospital and are started on PPI there, who are started with an IV, usually IV Protonics, those patients I do see their effect a little sooner, because the IV dosing does get into their system to the effective level a little more quickly.
Okay, and so can patients use a PPI as needed?
So no, PPI should not be used as needed. To truly have the effect that it is needed, it has to be taken daily, and it should be taken for, as I said, at least a few weeks to see what effect it does have.
Okay.
If a patient did need as needed acid suppression, the H2 blockers are a more reliable use for that.
Okay. And do you have any patients on baclofen as a prokinetic? And if so, what dosing do you use with that?
I personally do not use, I don't have any patients that I have on baclofen. I know we do have 1 or 2 in our department who are on it. I'm sorry, off the top of my head, I do not know the dose for the baclofen, just because I don't use it very frequently. Although there are quite a few studies for some patients with very difficult to control regurgitation or gastroesophageal reflux who do respond well to baclofen.
Okay. And what is the role of allergy testing, including gluten testing?
So where indicated, testing for celiac disease, specifically for the gluten, that could be worthwhile for most patients with gastrointestinal disease that's not responding to standard therapy. As I said, there is a little bit of a correlation with patients who have type 1 diabetes as well as trisomy 21. It would be a relatively simple test to perform in such patients who are presenting with gastrointestinal symptoms, to check for a celiac panel, just as a screening for those specific patients. And patients who aren't responding to standard therapies for constipation or acid reflux also could potentially be screened. If there's a family history of celiac disease or type 1 diabetes or other autoimmune diseases, doing a screening for celiac would also likely be indicated there too.
And when do you start testing for food allergies?
So specifically for food allergies, I usually do not do any testing in relation to abdominal pain, GERD, or constipation. The likelihood that any of those tests is going to have much clinical weight in finding a specific trigger for symptoms is rather low. Even in related to GERD, eosinophilic esophagitis, they're not usually very helpful in directing management. Their value is really only in specifically food allergies themselves.
Okay, and if you had a patient with functional abdominal pain and you felt it was stress related, when do you get a psychologist involved, or do you refer to them?
I frequently refer almost all of my patients with any kind of functional abdominal pain to start counseling to work on things. The vast majority have stress or anxiety, whether it be one or multiple triggers, and working with either a psychologist, counselor in some fashion can be extremely helpful, more so even than many of the medications.